your nerves burn. So I'll talk about it, but that's what you're looking at. Okay, today in this video, we're going to be talking about radiofrequency ablation, which is called RFA. The video you're about to watch is I went to Kinetic Spine because of all my pains throughout the body and everything from the accidents plus from life in general. It's a long video. It's a doctor explaining, and this doctor is the best, everything about my body and what radiofrequency ablation is about. Of course, I've been in an accident, screw loosen up a little. I'm finding out now that when they did my neck surgery, the ACDF, that they don't clean out all the cartridge that's inside of you. There's a little bit left in the back because they can't go back near the spine because I can be paralyzed. So they get as close as they can. Then they put the 2 discs. So that all worked out fine. Well, it's not the screw that really is affecting me. It's what it is that in the back from the accidents, that what little left cartridge is pushing literally on the nerves. Okay. And because I take pain medicine, my endorphins are spreading more, because what happens is when you take medicines from here on down, your body doesn't feel no pain. So your brain is saying like, hey, you're supposed to be hurting. So what it does is it sends out more endorphins out there. So the more endorphins that it sends out, the more sensitivity I am to pain. And you'll listen to one of his examples is like if you cut your arm and it hurts, and then all of a sudden you forget about it. Then all of a sudden you go into the shower and you run some water on it and it hurts again. You're like, oh shoot, I forgot about that cut. Well, in my situation is if I cut my hand, it's always going to hurt because of the pain medicine. He recommended that I take 2 leaves a day because a lot of it is all inflammation that's pushing up on the nerves. So, and then he recommends Lyrica. But if you listen to it all, and if I am going to take 2 leaves, I have to make sure that I get my liver and my kidney checked. But it's all, like twice a day. And it's supposed to be the most safest and the healthiest way to get rid of this pain. Now, he says if I'm in so much pain, regardless what I take, that pain will never go away because my nerves are beyond fixing. So basically what this radiofrequency ablation does is it burns the nerves on the end off. So if you've seen in the beginning, I went for a test, and let me tell you something, it is painful. It is very painful. If you can tolerate pain like BB, well, it hurts. But to me, oh my gosh, it was pain. What they do is they numb it up, and then they shoot Novocaine down each nerve. And then what's supposed to happen is that my pain's supposed to go away. So when he shot me in the back was like S1 but he if you listen to the video again, this is just a brief intro. Shows right here what each nerve does and goes to. So when they did mine's 4 here, 4 there, and then BB had here and here, which I'll be getting to. So what that test does, basically, when they shoot Novocaine through your nerve, I think it's a couple hours, and you have a chart, and you shouldn't feel nothing. All that pain should go away. I promise you. And then they want you to walk. They want you to lift stuff and everything. I promise you. Well, that pain that I went through was worth it because all my pain went away. Hell, I was lifting up drums of water just at ease and pouring it. And I couldn't believe it. I was like, oh my God, I'm going to suffer for this. And I didn't. And I'm getting my back done first. BB had her neck done, and it all worked for her. So I was like, okay, so, right at the last moment, of the hour, my pain shot back up, which is what's supposed to happen. Now, if they do this test and your pain doesn't go away from the moment you left that office, then according to him, as you listen, there's nothing, no pain medicine, no pill, no nothing. But his two recommendations to me is to get off the pain medicine because it builds endorphins. Once I'm off the pain medicine, my endorphins will shrink again. Because again, my brain is saying, hey, there's supposed to be pain there. So it's reaching out for that pain. The phantom pain. And a lot of it has to do because of inflammation. When he was touching my muscles up here, he noticed it all. And he says, yeah, you got to bring down that inflammation. And then the other thing, like the bottom of my feet didn't hurt. My pinky didn't hurt. So, as he was telling me about core muscles, and these are other areas, when they shoot, this is basically what if you're cramping in all these areas here for no reason. Yeah, that's nerves. That's your nerves. No steroids are being shot in me. No cortisone shots. I've known people who had cortisone shots and steroids, and it's eating their cartilage, and they're beyond repair. So that's another good thing about this here. Now, I went to Kinetic Spine. Don't go to these people, BioSpine. They're horrible. This is what the guy gave me to read on my own, and just shoved me off my way. Read this. Less than a minute, he talked to me. Read this over the weekend. Give me a call back. Let me know what you want to do. The doctor that's talking, Epperson, that's talking to me here, he explained everything from the beginning to the end. And according to him, because I haven't had that done yet, that the test is worse than the actual procedure, because the procedure is done by robotic, and you're numbed. You're fully numb back there. So if anyone has any questions or anything, just leave them below in the comments. But I do, recommend that you listen to it. It's going to be a long video, so listen to it. And he did tell me that I have to build my core muscles, because a lot of that too is because when I'm underneath a car and I'm pulling on a wrench, I'm twisting my spine. So all my energy is not coming from my arms. It's not coming from any muscles. It's coming from your spine itself. So that's why I noticed that when I work on a car, or I'm cutting the grass, or I'm bending over lifting up something, it's because I have no core muscles. I call it yoga, but basically it looks like stretches. But without building your core muscle, and it's not working out or anything, it's just, sitting on the chair, raising your legs, getting a can, spaghetti, and just doing that. But without building your core muscles, or doing that, without building those core muscles, you're basically using your spine, and you'll never, ever get rid of that pain. So that's another good thing that he had mentioned. So I'll be going for the procedure, and then I'll let you guys know after the procedure how everything worked out. I don't know, because of the pain levels that they did that, I don't know if I'm going to get my neck done. But if the pain goes away like it did in the test, most likely, God willingly, I'm going to get my neck done. So if you go to pain management, ask them, do you guys do, radiofrequency ablation, RFA? Because that's another thing you'll hear him say, that a lot of times when you go to pain management and other doctors, all they want to do is shoot you up with cortisone shots, steroid shots. Steroid shots, you blow up. Cortisone shot eats away your cartilage. Pain pills increases your endorphins. And he says that if you're at a point where you're past pain pill, past morphine, and he says he's known people that walk in there that take so much medicine, high doses, that can kill a horse, especially me, because once your body gets immune to it, that's it. It's no return. And once your brain starts saying, hey, I need that pill to stop the pain, it's over with, because that pain is that phantom pain. And I call it phantom pain. It's real pain. But that pain will always be there because your body's saying, I need the pill. And even though the pill brings it down a little or doesn't bring it down, it's basically, your SOL. There's no really cure. You're going to be like that for the rest of your life. So ask your doctors, and if they don't do it, find someone and make sure you check their background. All I know is here in Florida, this guy at Kinetic Spine, Dr. Epperson, I promise you, you'll hear him. And this is a guy you want to go to. So enough of that. And here's the video of my office visit.
I had a chance to look at your MRIs and the x-rays, not only the ones you recently had, but all the way back in 2019 to kind of compare those two there. So I understand that before this recent accident, well, let's see, back in December of 18 you had an accident. And then there was another one February of 19, and October 31st of 20 was the latest one. From those previous accidents, is that what triggered you to have to get the surgery?
No. I had a spur and
that was even before. Okay, so that was June.
And then I had one of these things inside were no good.
Okay. Yeah, one of the discs.
Yeah, so they put a plate there. They put 2 discs, and then they grounded out the spur that was pinching the nerve.
All right, and that I understood took care of the arm pain.
Yeah, I mean,
like you had before the surgery.
Yeah, because I was like 1 year of pain before they realized what it was. So it was like right after the surgery, I felt like I hit the lottery.
Right.
I mean, compared to that pain, anything felt better.
Yeah.
And then all of a sudden, someone hits a red light and hits me, and then
what was that? December 2018 accident.
Yeah. Yep. Then the pain came back.
The pain in the neck and the arm.
Yeah. All that pain that I got away came back. So then
only a few months later, that stinks.
Right. So then I felt like, okay, it was getting a little bit better. And then all of a sudden, come February, someone hits us from the back.
Again.
Right. So then from that point on, it took I was sore, like if I did something, but it wasn't as bad. Then all of a sudden, someone hit us head on, and it's like.
Is that the recent one, the October one?
Yeah, okay. And it's like, that came back.
Okay.
Well, I know like the strength in my arm, I don't have no more, because that was one of the things. I felt like the other 2 times my strength was still good, but this one here,
So just before the October 31st accident, you were still having some pain in the neck and the arm?
It was like really low, like manageable.
Okay. Did you complete all your treatments from that February auto accident, or were you still in the process of undergoing treatments?
I was.
The 19 accident.
The 19?
Mm-hmm. Yeah, February 24th, 2019.
I was still doing treatment, like the first, and then overlapped the second, so then I just did the whole treatment. Yeah, I did.
And did you complete all those treatments before the October 31st accident of 2020?
Yes.
Okay.
Yeah. We just finished, and because that had to be around April or something.
And those treatments helped it. It got it to a tolerable level to the point you didn't have to keep going on a regular basis.
Right.
Or were you still getting occasional?
Well, then at this point now, I was at pain management. Then I started doing pain management at 19 when that second accident came.
Okay. In pain management, they were doing injections for you?
No, they were just giving me Vicodins.
That kind of pain management.
First. Well, it was Vicodins at first. And then, of course.
Oh, you're still on them.
I had a shooting pain down my leg. I wasn't so much pain at that time, but every time I went there, she was like, I'll give you a cellulitic thing, and I was like, no. Then finally I was to a point where I was like, listen, this is what I want when you do this to me and everything, and boom, she gave me that. I felt like the pain, again, from what I was to I couldn't walk, I felt good, better. Then of course, then this accident happened.
talk about the pain medicine and stuff like that. It's going to be a guaranteed way for you to live in chronic pain for the rest of your life, and I'll explain that to you in more detail. But there's a reason for the fact the FDA has never approved the use of narcotics for more than 2 weeks at a time. All right, so I want you to understand that, and then you can make your decisions about what you want to do. But I've been treating pain patients for 16 years. Never once have I been able to get someone's pain to go away when they're on narcotics. Right? Because they will cause pain. They actually cause pain.
Okay. Yeah, because I know like when I have pain, yeah.
So, but
nothing.
Again, it's our main purpose here, just more education, let you know these are your options, these are the good and the bad of each option, right? So that you can decide what you would like to do as you move forward. All right, so before the October 31st, 2020 accident, was your back pain under control? Was it gone? Were you taking those meds and stuff primarily for the neck and arm?
No, that was still there. I had sciatic pain and...
But that was being controlled with the medicines as well?
At that time, yeah, it was bringing it down a little bit.
Yeah.
And then, like I said, then it had gotten worse to where...
After the accident got worse?
No, it had gotten worse to where 2 months prior to the accident, she gave me the celiac shot. The hip shot or whatever.
Okay.
Then all of a sudden I felt better, and then all of a sudden I get into this accident. It was like...
Into both legs like it is now?
Yeah.
Or is it different? Okay.
No, it's the same. It's just the left seems to be the worst. Why I went to pain management because I seen a rheumatoid arthritis doctor, and he says that he diagnosed me with chronic pain syndrome. He said he couldn't do nothing at that point. That's why he sent me to pain management.
Intervention.
Yeah, pain management.
Yeah, that's what I do. Also, interventional.
Yeah.
I'm a big advocate about getting off narcotics, and
She
we'll
is too.
talk about.
Oh, trust me, yeah. I don't like steroids shot into me, and I'm not a fan of needles. Like,
Well, sure. No
Like
one's coming in saying, "Hey, can you please put a needle in my neck?"
No,
Not if you're normal.
Right?
no, but what I'm saying is,
Yeah, people that say, "Oh, I'm good with needles," those ones I'm concerned about. Everybody should have some fear of needles.
Yeah, exactly.
That's normal. Let's talk about the pain you're currently having now. So, the pain in the neck and down the arms, you had some of that to some degree before, but it was aggravated in this accident. Were you also having some of that pain over the shoulder blades that was aggravated, or is that a new
it was
thing?
all like, just
So
like
all that kind of got
up
aggravated.
here,
And the trapezius there.
right, and then up. This was always from the blade all the way to the elbow to the arm. I was having spasms
Okay.
that I couldn't even sleep at night.
Yeah. And that all got aggravated.
Yeah.
Gotcha. Okay. How about that chest pain you've been feeling now?
Now the chest
Is that a new
pain,
thing?
no. That's even when I had this here going on. Chest pain, I would get flashing across. And it just like it was like every now and then. It wasn't really.
Intermittent.
Yeah, right. And because at first I was thinking like, shit, am I having a heart attack?
Right.
But then I think when I looked it up, or when I talked to my rheumatoid arthritis, he says that's all nerves. But still treat it like it could be. But he said, like that flashing that I was getting across is that my nerves are all throughout my body. It's just
Dr. Amen also said that too before he did the surgery. Is why you were getting some of that pain radiating down from the neck and the chest.
Into the chest.
Yeah.
All right. So all of that got aggravated. Even the chest symptoms got aggravated in this accident, and then the lower back and legs again. Nothing new is there. It's all just an aggravation of what was there before.
It's like it's worse because now the bottom of my feet are hurting, and then these two toes here.
Yeah, on the outside edge there.
Feel like someone put an ice pack on it and left it there.
Yeah.
This leg falls asleep constantly, and the tingly's always been there, but the tingly, like everything's all amplified more. So it can be like a 10 to literally like if I walk a lot or bike or anything, and everyone's like, do you got diabetes? And it's like, no, I don't have diabetes. But it takes me up to 2 minutes just to get to a slow pace, because it just hurts so bad. And then I just have to, when I start moving, of course, as time passes, I feel like the pain goes away. But then the minute that I sit down for a while, it's like I feel like I'm 100 years old. The second accident is where my cramping started, and then this accident, it came back again. But the second accident, I had cramps, and then I felt like it went away. And I was cramping in the middle of the night, sleeping, everything. And that's another thing that I didn't have prior to that. I didn't have muscle cramps. And I was just like, thinking, drink water, drink this, drink and.
Yeah. And then none of that stuff helped though, right?
No.
Yeah, so there are different reasons why we can have muscle cramps, dehydration, electrolyte imbalances, low magnesium, things like that.
I do have restless legs. I know I was diagnosed with
but you can also have irritation in the nerves in your back from disc herniation. It can also affect the signals going to the muscle. And if the signals going to the muscle are they're not what they're supposed to be, if they're not the signals coming from the brain, if there's something being triggered by a disc pushing on the nerve and activating the nerve, then you're going to get weird sensations. It could be pain, it could be numbness, could be tingling, could be the muscles cramped. People will even have swelling in the legs. Have you noticed any swelling?
Like around here, sometimes if I walk a lot, I notice some swelling.
Yeah. And it's because the blood vessels in our legs also have to constrict and dilate based on our position with gravity, right? Because when we stand up, the blood's wanting to rush down, but when we lay flat, the pressure changes in the blood vessels in our legs, and they have to respond by contracting or relaxing. Well, again, if the nerve that's going there is not sending the correct muscle, they don't do it properly, so we end up with extra fluid down there because we got too much blood. The blood vessels are too dilated, they're not constricting enough to balance everything out. So those are all signs of the back. All right. Same thing. The restless leg is probably not. Restless legs, I think, is really more of a diagnosis of a symptom. The restless leg is a symptom, just like the pain is a symptom, and the swelling that you have there, and the numbness and stuff. Those are all symptoms. It's not its own diagnosis. If you get rid of the back problem and you get the irritation that's occurring to the nerves to go away, you don't have a restless leg. Your legs will feel fine. They only feel restless because you have all these weird sensations going on down there.
Right.
You can't find a comfortable position.
I was putting holes in the sheets.
Right, yeah. Constantly moving and rubbing, trying to.
Yeah. And the other thing too, I've noticed after this accident, is like my toes feel like they're going on top of each other when a cramp comes through.
Yeah.
That felt weird, like they were twisting.
So the diagnosis of like restless leg syndrome, you should never give somebody that diagnosis until you've looked for all the other causes that can cause pain or numbness or tingling or weird sensations in the legs. But if you can find another reason for it, like a disc herniation, which you have 3 of them in your lower back, you don't give someone that diagnosis because you have another cause. You have a much more likely cause, right? It's only when you've done studies and like, there's nothing on the MRI, there's nothing in their blood work, there's nothing here that would cause irritation of those nerves that we can find with our current studies. That's when you throw that diagnosis on there.
Because I know they gave me a nerve conductive test.
Yeah, an EMG.
Yeah, and that's when he told me, like, yeah, that's another thing I don't like doing. Yeah, that's another thing.
Yeah.
That's when I
Did
went
they
back.
tell you that there was going to be needles involved with that one?
No, I didn't tell him.
Oh no, like
Me or his mom.
Put it to you this way, at that point,
shocks and needles.
I would have loved the needles. The shocks were the ones that were killing me.
Right.
That I wanted to beat the hell out of.
Yeah.
But that's when, after my rheumatoid arthritis did all these tests, that's when he came up with this chronic pain syndrome. So that he couldn't do nothing for me.
So that's, pain is an appropriate thing for somebody to experience if it's consistent with an injury or some sort of pathology that you can define and stuff like that. But, you know, the body tries to heal itself, and when we have pain that persists beyond 3 months, because most things should heal within that time, just depends, you know, sometimes you'll give it a little bit longer, but by definition, chronic pain is pain that's persisted more than 3 months. You know, there's other definitions, you know, pain that persists longer than expected for the injury sustained, you know. But yeah, after you've had it for that long, then you automatically get that diagnosis of chronic pain syndrome. So it's, all right. I think I got all that information, been through all this. Those medicines you're taking with the gabapentin and stuff, do you feel like that helps your arms and legs?
I mean, she thinks, I mean, there's certain times where I'm restless, and then there's other times I'm not restless. But I take that one time.
One time.
Yeah, because you can't take it like they want you to.
Yeah. I know, I was about to ask, you're on an extremely low dose of that.
Yeah,
they wanted him taking it 3 times a day, and he can't.
Yeah.
He's even tried, you know, in the morning. And in the morning, he's so sleepy, he's sleeping all day.
That's the downside to that medicine, because it causes a lot of sedation. But typically, what I've experienced with gabapentin is that people typically don't start getting good results until they're up to about 900 milligrams a day. You can go all the way up to 3,600 milligrams a day. You're on a baby dose of that medicine, but some people just don't tolerate it, and that's probably the most common side effect is sedation.
Right.
Did they ever try to switch you over to Lyrica?
No.
So gabapentin is the old school when it was developed, back in the 60s, and it was first developed to treat seizures. The medicine is supposed to kind of calm nerves down, and that's what seizures are. You know, your brain activity gets overexcited, and then just things go haywire, and it causes you to, you know, shake or tremble or whatever kind of seizure someone has. So the gabapentin was designed to help calm those nerves so they don't get overly excited and people don't have seizures. Well, they started giving it to patients. They found it wasn't working that great to control seizures, but the patients with seizure would come and say, yeah, I'm still having seizures, but that numbness down my legs got better. So for years, decades now, we've been using gabapentin off-label. It's never been approved to treat arm or leg pain or numbness or tingling, nerve pain in the periphery, in the arms or legs. It's only been approved by the FDA to treat seizures. But because it went generic by the time that was discovered, there's no company that's going to do the studies to submit to the FDA to get the approval to treat it for peripheral neuropathy, which is, you know, pain in the arms or legs. So it never actually went through and got that approval, but that's what we use it for. We hardly ever use it for seizures now. It's always used to treat nerve pain in the arms or legs. But the whole point of the story is gabapentin was the old one, and back in, it's probably been at least 15 years now, they came out with pregabalin. Pregabalin is also called Lyrica. It's the next generation to that medicine. They kind of modified the molecule a little bit, where it's easier to dose. It starts working a lot faster, and it has fewer side effects. Most insurance companies, though, would deny coverage on it until you've had a trial of gabapentin. But that's what surprised me. If you were on gabapentin and they said, hey, you know, go up to 3 times a day with that 300 milligram dose to get you to that 900 milligram dose, and you're like, I'm too tired, I can't do it. Why they didn't document that and switch you over to Lyrica? Did you ever talk to them about that?
That was given to me. Was it given to me by
Romero?
It was
Down for you, some of that info down for you. I don't want to step on something if someone else is prescribing.
No,
I don't want to step on their toes.
No,
Stuff like that. I
this
want to
was
give you the
coming
information
from,
so you can.
right. This was coming from someone else.
Yeah.
Yeah.
Have you tried just using like 2 tablets of gabapentin at night instead of taking it 3 times a day? Just taking it all.
You
at night,
were
or does it
doing
still
that,
make you tired
and
in
then
the
you were
morning?
still so tired.
In the mornings, yeah.
Yeah. It was
Okay.
taking you
Like I
forever.
felt like I slept good,
But then he
but
like,
then if I sit on the chair, I would just pass out.
Yeah.
And I've never done that before.
Yeah. So that's all the information that you give to them and say, hey, here's what's happened with the gabapentin, right? Because they have to document that, because If they write you for Lyrica, they'll probably get something from the pharmacy saying this medicine needs a prior authorization. In that prior authorization, you have to put in there what medicines the patient has previously tried and why they can't use them. All that has to be documented in order for you to be able to get approval to even try the Lyrica. But yeah, I found that most patients find that Lyrica does work better. It's, you know, it still has its share of side effects and stuff like that. But again, like I said, it's much easier to dose. Like I said, gabapentin, you gotta start a dose, give someone a week on it, then bump it up to a higher dose, then go another week, then bump it again, and you're bumping it by a few hundred milligrams a time, trying to get all the way up to either their symptoms are controlled or you're at the maximum 3,600 milligrams. Could you imagine 3,600 milligrams? That's like, what, how many times?
Cronin had me at 1,500.
Yeah.
I said, listen, I'm with patients. I don't need to feel like I'm in a fog and
Right.
screw someone up.
I've had, over my career, I've had like maybe one patient who's been able to tolerate 3,600 milligrams of gabapentin.
I don't see how.
Yeah, that's the weird thing is we're all a little bit different though, right? And then how we respond to meds. So Lyrica, typically 150 milligrams is a therapeutic dose, and you can start it out either 50 milligrams 3 times a day or 75 milligrams twice a day. For simplicity, just do it that way. And usually right there at that first 150 milligrams is usually as far as you have to go. You can bump it as high as 300 milligrams. But the dosing on it's a lot faster. You know, you're not having to titrate for so long. You know, it literally takes months sometimes to get someone titrated properly on gabapentin. Let's take a look at where your pain is. Let's do an exam and stuff like that. You know, the MRIs did show some changes. Did they review these with you already? Talking about what they
No.
So in your lower back, it's really the bottom 3 levels that showed the changes there. The five discs in our lumbar spine. So lumbar is in blue here, then thoracic and cervical up here, the sacrum's down here. So when we talk about a disc, you have to name the bones that are on either side of it to define the disc. So like this disc bulge or herniation here is an L4, L5 disc herniation. All right, that would be L5, S1. All right, that disc there. So we have 1, 2, 3, 4, 5 discs in the lumbar spine. These 2 are normal. These 3 are abnormal.
I know I could have sworn I had something like this, and I thought they cut it, infused it. That was
In your lower back or your
my lower back.
Oh, your lower back.
Because I had surgery like in 2007.
I put all Dr. Amen's information on there.
Okay, yeah.
Yeah, the business, the phone number, if he has to get a hold of Dr. Amen.
Yeah, but I know like that there.
Cause he did both the
Lower back in
surgeries.
7, okay.
Yeah.
Gotcha. Yeah, so we'll get those drinks and stuff like that. So, when we have problems that have developed in the disc, whether they're disc bulges or herniations, protrusions, extrusions, whatever term the radiologist used to describe the abnormality, they're all abnormal. A bulge typically involves more than 25% of the circumference of the vertebral body, that part of the bone there, and a herniation is less than 25%. A bulge and a herniation has no indication as to how far it sticks out, right? It's just how much of it does it involve. So this going pretty much all the way across the front side, that's a disc bulge, whereas this being more focal in there is a herniation. You can actually have a disc bulge with a superimposed herniation on top of it, okay? So that's what those terms describe. The location of where the herniation or bulge is occurring on the disc is one of the most important things, because like this right here would be completely asymptomatic. That wouldn't cause any problems. And the reason for that is because there's no nerves right there. This probably would cause a problem because the nerve coming out of that opening right there, that disc herniates, takes up a lot of that space, so there's no place for the nerve to go because it's bone all the way around except for where the disc is, right? So as that disc herniates, then the nerve gets pinched. Now, if you pinch this nerve, this is the L4 nerve. It's the L4 vertebra, so that's the 4th lumbar nerve off to the left side. If this were a real person, they would probably have pain or numbness or tingling going down their left leg, but it would go from the back over the side of the hip, it would cross over here to the top of the knee, and then go down to the inside of the foot, because that's the distribution of that nerve, right? So when we have pain or numbness or tingling that radiates into our arms or into our legs, the location of those symptoms are what tell us which level's the problem. You can have 3 different disc herniations, but maybe only one of them is problematic, right? So disc herniations can be a completely asymptomatic thing. A lot of people have them. Just because you have disc herniation doesn't mean it causes pain, but when it does so because it pinches the nerve. So the pattern that these nerves travel in is called the dermatomes. All right, here's the picture of them. So I just described to you the pattern of the L4 dermatome. You can see as it starts there in the lower back, it's the kind of that purple color, the second one from the bottom. L5 is at the very bottom there, but L4 comes across through the buttocks over the side of the hip, but immediately comes to the front of the thigh, across the front of the knee, all the way down to the inside edge of the foot, right? S1 is the one that shoots all the way straight down the back of the leg to the side. So where you get that numbness in those toes out there, I think something's irritating the S1 nerve, right? It's because of its location. See where it goes to the little toes, right out there? The pain on the bottom of the foot is probably the L5 nerve, right? The L5 nerve starts from there, comes through more the side, right in there. But as it gets past the knee, it starts to wrap towards the front, goes to the top of the foot. So they all have their patterns. Same thing up in the neck. You know, C6 goes to the thumb, C7 to the index and middle finger, C8 ring and little finger, and they all have their patterns. Because you have these pains and abnormal sensations occurring in a lot of these patterns. And even when we did our physical exam, it's like, it wasn't like normal here and abnormal here. It was abnormal all the way around, right? So the only way for you to get these abnormal sensations all the way around your leg is either you have disc herniations at every single level that are coming out and pinching the nerves all simultaneously, which is not going to happen, or there's some other cause for the irritation of these nerves. Now, the other common cause for irritation of these nerves is something called an inflammatory chemical neuritis. That's a fancy way of saying that the nerves are getting irritated because of chemicals that are being produced. When our body has suffered damage to a tissue, whether it's a disc herniation, damage to the joint, arthritis, a torn muscle, heck, a cut on the arm, cut on the skin, the body enters into an inflammatory reaction. And that reaction, it produces chemicals, histamines, prostaglandins, interleukins, leukotrienes. All these chemicals start to accumulate at the site of tissue damage. And as those chemicals accumulate, they'll start to spread into the surrounding tissue. Now, if you have, say, damage to these joints back here, and these joints are becoming inflamed and irritated, as they get irritated, they're going to cause these muscles to get irritated, not because there's any problem with the muscle, but because it's responding to those chemicals. The muscle goes into spasm, and then you start having muscle pain back there. You don't have to do anything about the muscle spasm, it's not the problem, it's the symptom. Right? But that's if the chemicals move posterior. But what happens if the chemicals move anterior? Well, anteriorly, you know, there's the joint, there's the nerve, right there. So as the chemicals move forward, they can get on these nerves and irritate the nerves, and that can cause people to feel like my whole leg is numb or tingly or feels weird or something like that. I suspect you got kind of a combination of 2 different things going on. I think you have to some degree a diffuse inflammatory chemical neuropathy from damage to these tissues back here that's causing that inflammatory reaction, and those chemicals are irritating all of the nerves, giving you these weird sensations throughout the whole legs, left, right, both arms, throughout the whole area, not following any one pattern. But on top of that, I do feel like there's probably some irritation, further irritation to the nerves due to the disc herniations we see. And that's probably responsible for almost that different pain where you feel like this different thing happening in that left toe. Different than everywhere else, right? And the pain on the bottom of the foot, again, different than everything else. Those 2 things are probably due to some more direct nerve irritation due to the disc herniations, right? Similarly, in your neck, again, when I compared this to the old one, this one showed, of course, you had the previous surgery from C5 to C7. There is C6-7, there's arthritis in there, there's some narrowing of the openings where the nerves exit, there's some residual disc material that's extended posteriorly and laterally at that level. So what that means is when they did the surgery here between C6 and C7, there's 5, 6, and 7. That's where your plate is, right up on the front there. Then they put screws in those bones to anchor that plate in place. And when they did that, they tried to remove some of this disc material, and that's what takes the disc herniation. The disc herniations, when they occur posteriorly, that's where they pinch the spinal cord of the nerves. The disc herniations anterior don't cause problems, but they have to remove them to put the plate on there. Well, this level here, they didn't get all of the disc material out. They didn't remove 100% of it, because even after your surgery, the MRI from, was it 2019 or 2018?
Because I thought he put 2 plastic pieces.
Little spacers in there.
Yes.
Yeah, so they do that. They remove a portion of the disc, but how much of that can they get out? You know, sometimes they can't get all of it out, right? But when they remove that part of the disc, those bones are gonna wanna collapse down, so they have to put a spacer in there.
Right.
Alright, so they did. So they removed some of the disc from the front sides here as much as they could, trying to get as far back as they could, but they couldn't get it all out. They put those spacers in there, then put the plate so that everything maintains proper spacing. The thing is, the disc material that was left behind in the backside herniated out, right? Now that was there even on the older study.
Mm-hmm.
Is it worse? It's hard to say. I mean, you look at both of them and they're both sticking out. I mean, if it is worse, it's, you know, just minuscule progression of it and stuff like that, but that certainly could still cause impingement to some of these nerves, right? But again, we're seeing that it seems like almost all of these nerves are getting irritated because of how our exam on the neurological exam to touch. It's like, yeah, none of these felt normal, right, to touch. So again, I feel like up here in your neck, we're probably dealing with a combination of both that diffuse inflammatory chemical neuritis, where all the nerves are getting irritated from inflammation, but also probably a little bit of more focal disc herniation causing nerve irritation individually. It's hard to differentiate. When the whole arm feels weird, how can you say, oh, there's also numbness going down into the thumb, consistent with the C6 nerve, right? Because that other sensation kind of masks it all blends together, so it's hard to pick that out. Your physical exam is also very suggestive that you have a lot of pain coming from these joints back here, right? And the reason for that is because when we bend our head forward, or our lower back, when we bend forward, these muscles that attach to the backside, they're all tight. I could feel them when we were doing the exam. You know, a lot of spasms going on here. So as you bend forward, you're gonna start to stretch those muscles. So you'll feel some pain, but like you described, it feels like a rubber band, right? That's kind of what it is. I mean, these things they're trying to pull back like this, and you're stretching them out like this, but they want to bounce back like that, you know, so it's kind of that rubber bandy feeling. But the pain that you had was different when you tried to lean backwards. When you tried to tilt backwards, it caused a different sensation, because going forward, you were stretching the tight muscles, and that was the pain you were feeling. But as you bent backward, you were putting pressure on these joints. And as you do that, if the joints are inflamed and irritated, that's going to cause pain. Same thing if you bend, tilt your head left or right, that's going to put pressure on the joints and stuff like that. So I think there's probably a combination of some of those things happening there. Because there's more than one thing that's contributing to all of the symptoms you're having, there's not any single thing that we can treat to get rid of it all, right? This is something you have to kind of go after one thing at a time, decide what's causing the biggest problem. You know, what are we most concerned about? And then try to treat that first. And then once that's under control, then reevaluate. Now, what pain went away with that treatment, and what's still lingering? Now, what's the next problem? What's the next biggest problem? Let's take care of that, get that under control. We just gotta kind of keep chipping away at it till we get this pain under control, to where you don't need those medicines anymore. The damage that occurs during automobile accidents can involve everything in the body, right? And there's no study that we have that shows everything. MRIs, they're limited to what you can see. Like an MRI, you can see these muscles back here, but you can't see if they're torn on an MRI. You just see a big blob of black stuff on an MRI. You say, okay, well, that's muscle. But you don't have enough resolution to see like this muscle coming down and attaching to say, oh, look, that was torn away from its attachment point. You can't see that. What you can see on an MRI is disc herniations. Right, so that's the reason we do those, really to see what the condition of the discs are. X-rays and things like that, they can show the bones pretty well, but they don't show any of the soft tissue stuff. So if you have like arthritis in these joints, over time, you're gonna get bone spurring forms. And you can see those on X-ray and stuff, and gives us more clues. But again, those studies, X-rays, MRIs, CAT scans, PET scans, all these different diagnostic studies, none of them are studies of pain. They're all just different ways to look at the anatomy. And then we have to correlate what we see on those studies with what you're feeling to try to figure out which of those abnormalities that we see are actually causing your problems, right? When these joints in our spine are hurting, that's what's going to cause a lot of that pain in your neck, trapezius muscles and stuff like that, lower back, buttocks. They have a very different pain pattern than the disc herniations, right? So that's the pain patterns from the problems in the joint. If you suffer damage to the joint's inflamed, it's going to be painful. And if the joint's in your neck, that's where you're going to feel it, down over the shoulder blades, out over the trapezius muscles and stuff. And that's what you were describing up in here.
Yeah, that's what I feel like right now.
All of that,
Right.
Joints in the lower back, all across the lower back, get down into the buttocks, and it might creep into the thighs, and it can be the back, the sides, the front, growing, but it's not going to go past the knee, right? So just that pain back in here, that's probably more joint-related pain. Again, we can do different things to try to treat these things, but there's not any one thing that we can do to get rid of all of it, right? At this point, it seems like with everything kind of feeling weird, these tingly sensations everywhere and the pain that you have in different spots and stuff, like I said, I feel like there's a lot of inflammation occurring in these areas in your neck and back, either due to the injuries from the auto accident, the pre-existing injuries over there from previous accidents, the surgery, which has changed the anatomy a little bit. These are all possible causes and contributing factors to that inflammatory reaction occurring. If we don't keep the inflammation in check, this is what happens, right? And when we get inflamed, we're going to experience a higher level of pain. That's what those chemicals, they cause the changes that we associate with inflammation. Redness, warmth, increased blood flow, swelling, pain, sensitivity. Things are sensitive. Like if you get a cut, it's like, if you don't bump it or anything, you almost forget that it's there until you jump in the shower that morning and soaping water hits it, and you're like, oh yeah, okay, yeah. Forgot that hypersensitivity of that area was the inflammatory chemicals causing that, right? But imagine that same thing happening deep down in your neck and lower back. Anything you do that moves that tissue, you're gonna be like, oh, that hurts to do, because it's hypersensitive due to those chemicals. If we can reduce the concentration of those chemicals, it can help to ease some of the pain you feel and reduce some of these weird sensations you have in your arms and your legs. Again, it's not going to get rid of the cause of the inflammation, but it's just going to settle it down. Then, once we get it to settle down, then we can go in there and try to target the individual causes and get rid of those individual pains. And really the key for long-term improvement, because these treatments that we do for these, they don't get rid of the problems. Again, disc herniations are permanent, they don't go away. If we suffer damage to the cartilage in our joints, cartilage does not regenerate, right? That's why arthritis is a chronic condition. You can't regenerate cartilage. So if we have damage from an automobile accident, which is the most common thing that I see, by the way, after an auto accident is damage to the joint, that cartilage damage doesn't regenerate, so you can have chronic pain from it. But because these injuries are permanent, we do these treatments not to get rid of the problem. It's a permanent injury. We can't get rid of it, so we've got to manage it. So we do these procedures and treatments and use medications to try to get the symptoms under control so that you can be more proactive, so that you can function, so that you can live an enjoyable life, so that you can work on a car and pull a motor and swap out a transmission without, being excruciating pain that night, right? The most important thing for that to help long-term are doing the exercises, right? So exercises that target the core muscles of our spine are the most important ones, and that's what all of these are. There's some for the neck, mid back, and lower back. I'll give you these to take home with you. These exercises all focus on these muscles back through here, right? All the muscles that attach to our spine, those are core muscles. because we can't get rid of the disc herniations and we can't get rid of the damage to the joint. Every time you bend and move and twist, you're putting forces through those structures. Well, you're also putting forces not only through the discs and the joints, but also through the muscles and the ligaments and the tendons, right? And those forces are kind of being divided amongst all those tissues depending on how the forces are being exerted through them. We can't do anything about any of those tissues except the muscle. It's the only thing we have control over. But if you make the muscle stronger, it's gonna take up a little bit more of the workload when you bend and when you're trying to get that training up in there, you know? All those movements you're doing are putting strain to your spine. The spine is just the anchor point, right? So if we make the muscle stronger, the core muscles stronger, when you're trying to lift something like that, you got those core muscles are contracting to stabilize your spine. But if those muscles are weak, as you're doing that, now your spine's being pulled off to one side or the other because the forces are very rarely nice and equal, like you're on a bench press where it's even, right? Especially working on a car. Love working on cars. But you get in some weird positions trying to get into stuff, you know? By making those muscles stronger though, the muscles will help to hold the spine in better alignment as you do those things, and that's gonna slow the progression, right? That's what's gonna make a difference. You know, what's gonna happen 10 years from now has nothing to do with the medicines or the injections or procedures or anything like that. It has everything to do with how strong you make your core muscles, right? So there's a lot of different exercises in here. Everybody's injuries and problems are a little bit different. Your body is going to tell you more than anyone else can. If you do an exercise that aggravates your pain, skip that one, move on to another one. Or maybe don't do it as aggressively, right? You know, just, you know, one of these exercises right off the bat here is showing stretching the neck this way. Well, if you can go to here and it starts to hurt, don't try to pull through it. Because that pain you're feeling is your body telling you, hey, you're aggravating the problem. You got to take that feedback from your body. That's a good lead into why pain medicine is bad, right? You take those Vicodin, those pain pills, and it blocks the pain signal at the level of the brain stem, right up here. So you move, you do something that aggravates the problem, that pain signal shooting up to your brain to try to tell you, hey, you're making the problem worse, but you've taken that pill and the signal gets stopped right here so it doesn't reach your brain, and you're like, that doesn't hurt, let me go ahead and do this. But what have you done? You've made your problem worse. You're guaranteed to never get better if you do that. It'll continue to make the problem worse and worse and worse to the point that those medicines aren't effective. Then you gotta go to higher doses. And eventually you can't go any higher on the hydrocodone. You gotta go to oxycodone, and then you gotta work your way up on that. And it's just a ladder. That you'll always have to keep getting pain pills. You'll always have to continue taking them. And, you know, probably what a pain in the ass it is to go and fill those things.
Yeah.
Have you had issues with them?
Well, I mean, I can only do them every 30 days.
Yeah. So I've had a lot of patients have issues trying to get those things filled. But that's just one reason why pain medicine will never allow you to get better, because you continually mask the warnings your body's trying to give you. The other reason is when we take narcotics long term, because those narcotics block those signals from reaching our brain, our body's dynamic, it's always changing. And it responds to the problems that it's having. If we're not getting the pain signals to the brain, the nervous system thinks that there's a problem with our warning system, our pain system. So what your nervous system starts to do is it starts to make more pain receptors in the arms and legs, in the back, in the neck, in the periphery. Pain receptors are the actual thing at the end of the nerve that detects when you've done something. It triggers a signal to go up that nerve to reach your brain to say, hey, you're having pain here. So if you have an area, let's say an area here on my leg that's about that big, and arbitrarily, maybe there's 10 pain receptors in there. And if I poke a needle in there, I'm gonna feel some pain because maybe I'll activate 3 or 4 of those receptors. And that signal goes to my brain and says, hey, you just got poked. Well, after you've been on narcotics for a while, what'll happen is your body thinks it's not working properly, so instead of there being 10 receptors there, now your body's double it, now you got 20 receptors there. Now you get poked with a needle, instead of activating 4 pain receptors, you're activating 8 of them. You experience a higher intensity of pain because of the pill. But the pill will fool you because you take it and you're like, oh, it feels so good. and then 4 hours later it's wearing off, and you're like, oh, my pain's so much worse. Well, it's worse because of all those things that we just mentioned. So it makes you think, I need that pill. So it creates a psychological dependence that you'll never get out of until you realize what these pills are doing to you. You'll continue to think, yeah, these are helping me. These are helping me. I feel better when I take it. It's a real thing, and it is a very real thing because, yeah, it blocks the pain for sure. But long term, that's the consequence, right? You'll never get better. You'll always have pain. I had patients coming in on 2 100 microgram fentanyl patches. I don't know if you know what fentanyl is, but it's 100 times stronger than morphine. It's dosed in micrograms rather than milligrams. That's how potent this stuff is. You put it on in a patch, and the patch is supposed to last 3 days. So this girl had 2 of them, one on each arm. 100 micrograms is the highest you can go on it also. The patch starts at 25, 50, 75, and 100. That's the biggest one. She had 2 of those, one on each arm. And not only would she use 2 of them, she wouldn't even leave them on for 3 days, because after 2 days, she felt like it was wearing off. So she would replace hers every 2 days. So she would put one on this arm, leave it on for 2 days. Next day she would put a new one here, and she kept alternating between the spots. And on top of that, she was taking, I think it was 10 milligram oxycodones, which is like Percocet, but without the Tylenol in it. It was just the pure oxycodone. 10 milligram tablets, and she was taking like 8 of those a day for breakthrough pain. She was on enough pain medicine that if you or I were given that, even half those doses, because we're not tolerant like she developed over the years, it would probably kill us. But that's the thing, is over time you become tolerant to those medicines, where the dose that used to work for you doesn't work anymore. So you got to go to higher doses to get the same effect. Anyway, she was on all these pills, all this medicine, and she came in and she said she was still having pain that was 8, 9, 10. How is that possible? Look at all these meds you're on. Why do you even take these meds if your pain is still in, up in the 8 to 10 range? Doesn't make sense. I convinced her to let me titrate her off those medicines. It took a year to titrate off the medicine. After she was completely off the medicine, she said her pain level was a 7. Her pain was better off the medicine than it was on the medicine. Just a story. I thought it would be helpful to share with you, because that's the road that you're on. Right? People get caught up in it all the time, and I don't feel like a lot of the doctors that prescribe these medicines take the time to explain that to people. They just say, oh, you're hurting, here's the script, and then they move on to the next patient, right? But it's something you got to understand. You got to be aware. You can decide what you want to do, but again, it's important that you understand the consequences of those choices, right? The gabapentin doesn't cause the same things. What we just talked about is just the narcotic, right? So nerve medicines that calm nerves down. Gabapentin, Lyrica, I think it's a good idea to talk to your doctor about switching over to Lyrica. I think that'd be a good thing for you. Did I see in your list you take any anti-inflammatories, Aleve, ibuprofen,
No.
So is there a reason why you can't do it? You have reflux disease. Have you ever had any ulcers?
No.
Do those medicines irritate your stomach at all when you take them?
I mean, like, I had my gallbladder removed because my stomach, that was irritating my stomach.
Yeah.
Ever since that, my stomach's been pretty good.
Okay. Number one side effect when using medicines like Aleve or Advil is that they can cause increased acid production. And if you're already prone to having gastroesophageal reflux disease, GERD, those can aggravate that. And they do that because they trigger the production of acid in our stomach, which normally we produce when we eat. And when that acid refluxes up into our esophagus, it's because the sphincter of the stomach, the muscle that tightens up the tube, when we swallow food, it goes into the stomach, but that muscle relaxes, lets food pass through, then contracts again to seal it off. So as the stomach's churning and digesting that food, the acid doesn't come back up through. Well, if that muscle's not tight enough, the acid seeps through, and that's what causes the heartburn feeling, right? Food being in the stomach acts as a buffer. So as the acid's being produced, it's being buffered by the food that's in there, and it kind of neutralizes it. And the acid starts to break the food down as it neutralizes it. But if we take those medicines and we don't have any food in our stomach, then we're producing acid, and there's nothing in there to buffer it. and that's what can cause the irritation of the stomach. So one of the things I think would be helpful for you is to be on an anti-inflammatory. Again, we're talking about how there's inflammation throughout the whole body occurring and how that makes you more sensitive to pain and causes these weird sensations in your arms and legs and stuff to occur. But if we can get the concentration of those chemicals down to a lower level, it's gonna help, right? It's not gonna get rid of your pain. And that's where people have this misconception that it's not that those medicines have two properties. They have pain relieving properties, and that's why we all take them. You know, you get a headache, you take some Advil or something, you expect your headache to go away in 30 minutes, right? That's the pain relieving property of those medicines. But with this kind of pain, they're not strong enough. You take them, you're like, they don't do anything for me, right? Well, the pain relieving properties come on in about 30 minutes. It will last for a few hours with those medicines. But the anti-inflammatory properties, well, they take about 7 to 10 days before they're even at their maximum benefit of reducing inflammation. The reason for that is those chemicals I was talking about that accumulate and build up, those medicines don't go in there and get rid of those chemicals. Your body has to flush those things out. Those medicines only slow the reaction down. So if you take an Aleve today, it's gonna stop or slow down the reaction that's producing the histamines and prostaglandins and interleukins, all those chemicals that cause that hypersensitivity and pain. But the ones that have already been produced are still there, and they're still doing their thing. So you take it, and you're like, I don't feel anything when I take this, right? But the key is you have to slow the reaction down long enough that your body flushes out those chemicals that were produced before you started taking it. And that process takes 7 to 10 days. So in this scenario, I like medicines that you don't have to take all that frequently. Advil, which is ibuprofen, only lasts 6 hours. So to get 24 hours of suppressing the inflammation, you have to take it 4 times a day. Take it every 6 hours. And that's hard to do, plus it's harder on the stomach. That's where Aleve has its advantage in this scenario. Naproxen is Aleve, but it lasts 12 hours. Right? So you take it in the morning, it reduces the inflammatory reaction all the way till the evening. Then you take a dose in the evening, and that controls you to the morning. But with those 2 doses, you're doing it all day long. 24 hours a day, you're suppressing that reaction. And then as time goes on, as your body starts getting rid of some of these chemicals, you'll find your symptoms are better. Again, it's not gonna get rid of it. But people tell me all the time when we do these injections, we have to tell them to stop taking those medicines. And they're like, oh, no problem stopping those medicines. They don't help me anyways. They stop them, and then 3 or 4 days later, they're calling up, it's like, oh my God, those medicines were, I didn't realize how much they were helping until I stopped taking them, right? And then they're saying, hey, what can you do to control my pain until I can do this procedure? You know, so they're looking for an alternative. So anyways, that's something to consider, right?
And I can take a leave every day.
Yeah. So you can go up to 500 milligrams twice a day, and you can do that long term. Now doing that, it's important to make sure you get blood work of your liver and kidneys periodically, but these are all within FDA guidelines, right? The FDA has done, well, the companies have done extensive studies and submitted them to the FDAs that show that using these medicines up to these doses, it's very rare to ever cause any problems with the liver and kidneys. Those are the most common things, that and the reflux. The reflux is the most common side effect, but the organ damages to the liver and kidneys. And that typically occurs when you exceed the maximum recommendation. That's why the FDA has set limits. Like, you know, this medicine, you can go up to this much, right? But to go beyond that, they say you can't go beyond that because all the studies showed that to go beyond that, that's when you get a big spike in the number of liver failure and kidney damage starts to occur. So yes, you can take anti-inflammatories every day. Now, they're not completely benign. Like I said, the longer you take them, the more likely they're gonna cause problems with the stomach. Because every time you take them, they're producing that acid. So again, it's something you have to be cautious of and mindful of. If you do find that they irritate your stomach, there are some alternatives, but again, it's one of those things that the insurance companies don't want to cover, things like Celebrex, which is an anti-inflammatory, but it has a protective mechanism to the stomach. You can also help the stomach by using things like Protonix or Nexium or something like that. Those are medicines you can even just get right over the counter now.
Yeah, I think I have a prescribed.
You already have one for that.
medicine
Yeah.
Yeah.
that I take every day.
Yeah, so those will help to reduce the problem infections in the stomach that those medicines can cause. And then if you're taking them on a regular basis, again, all you have to do is just, your yearly blood work where you check liver and kidneys. As long as everything looks good, you're fine. Now, using those medicines, there was some studies a few years back. There was a couple medicines that came out: Celebrex, Bextra, and one other, and I can't remember the name of it. But anyways, when these things came out, people were like, "Oh my God, it's a miracle medicine. It's helping with arthritic pain more than any of these other medicines had ever helped." I mean, people were taking them and be like, "Man, I'm painless. I mean, these are really, really helping." But unfortunately, they all started having heart attacks. And so it prompted this big study that was done where they were trying to figure out why are these people all having heart attacks, and of course it was due to those medicines. But when they did this study, they had to compare those new medicines to the baseline, right? So not only were they looking at those new medicines, the Bextra and the Celebrex and that other one, but they were comparing them to ibuprofen, naproxen, which is Aleve and Advil. They threw meloxicam in that study. They did diclofenac. Those are also anti-inflammatories, but just prescription, right? What they ended up finding out in the study is taking every one of those medicines still increased your risk of heart attack. Aleve and Advil, as you know, they're still available over the counter. But now, the FDA has mandated that they put what's called a black box warning on those things. And if you look on the packaging in those things, you'll see there's a little black box that says these things increase the risk of heart attack or stroke. Right? And that's what they found in that study. But they still allow them to be sold over the counter because they only increase the risk like that. Whereas those other medicines caused a big increase, right? The other medicines got taken off the market. Celebrex increased it a little bit, but not enough to remove from the market, so it's still available, right? But even naproxen, Aleve, was in that study. It did show a little bit of an increase, but again, the increase was small enough that they still felt, all right, it's reasonable, people can still do these over the counter. You can take it, even if you had a heart attack, the risk is so small with the increase in stroke and stuff. But again, these are all just things to be aware of, So that's something that could be done to really help out. So I think getting on an anti-inflammatory on a regular basis will help quite a bit. I think switching your gabapentin to Lyrica can help quite a bit. I think coming off of the Percocet, off the hydrocodone, you won't feel like it helps, but it will. As you come off, you'll feel like your pain is worse, but again, your body has to readapt. You've been on, 7 months now? Mm-hmm. So that whole time, your body's been slowly making more pain receptors. So when you come off of them, now you got all these pain receptors that are firing off, and you feel like your pain is worse than it is, but your body will do the reverse. When too many signals are getting through, it starts to take away some of those pain receptors, and it resets you back to your normal level. But that'll take some time. But that's another thing that makes it hard to come off the medicines. You start missing doses and going longer and longer between doses, and you have withdrawals from them and stuff. They can cause tremors and heart palpitations, and your pain shoots up. And again, it fools you to think, God, I really need these medicines, because I feel like crap about them. But you get through it. It's not a life-threatening condition coming off narcotics. People can do it cold turkey. Like I said, it can be miserable, but they can get through it. It doesn't kill them. The best way to do it is just slowly do it. If you take them 4 times a day every day, then just drop it down to 3 times a day and stay at that for a week or 2 weeks. Let your body kind of slowly adapt, and then from there, drop it down to just 2 times a day. Do that for a couple weeks, let your body adapt, and it minimizes those things and stuff. There's different procedures that can be done. I know how you feel about them. They can be done in a surgery center where you can get anesthesia. We can do them in the office here also, but in the office we can only use local anesthetics. And again, there's not any one procedure that's going to get rid of everything. Right? So epidurals are done not to treat neck or back pain, but to treat arm or leg pain. Again, the question is though, where would we do the epidural? Because right now we can't define which nerves are being affected. I think that L5 and S1 are in your legs because you have that numbness in the toes and the pain in the bottom of your feet. That's L5, S1. But I don't think L3, 4 is, because it would cause symptoms here. But not only do you have symptoms here, but you also got them in here and kind of all over. I don't think L3, 4 is a problem disc. I think it's more of L4, 5 or 5, 1, the most likely culprit for it. So we could do an epidural there, but the epidural injection would not be done to treat back problems. It would be done to treat these symptoms going into your legs. That's the purpose of it. It might help a little bit with the back, but the main reason is to improve the legs. That's a steroid injection. steroids. The joints though, we can inject a steroid into the joint, but we're not getting rid of the arthritis there, so it'll come right back. Instead, we do the radiofrequency procedure. That's a procedure where we put a needle down over the nerve that goes to the joint and get rid of the nerve. Once the nerve that goes to that joint's gone, you don't feel it. So it doesn't matter how bad the arthritis is, if there's no nerve that goes there to detect that, you don't feel the pain. And that's what that all describes. I think we got, yeah, it's going right there. So if we ever consider that procedure, we do a test procedure first where we just temporarily numb the nerve to see what kind of relief you get. And that way you can kind of test it out. That it helps to control your pain for a few hours, but how much pain goes away? Is it 10%? Is it 90%? That's what we find out. The response you feel for the first few hours when we do that test procedure is what we would expect to last long term after doing the radio frequency. So, and that's what that packet describes there to you.
Now, the radio frequency, is that for the, you're talking about for the neck or the back?
So radio frequency, that's the pattern you're looking at right there. So
Right.
that's what it would treat. Right? So radio frequency treats pain like that, it treats pain like that, and in our mid back it treats pain in that area. Right? Epidurals treat pain shooting down the arm or pain shooting down the leg. Right? So this shows what they treat. Right? That's the main purpose of those. So that second packet, the one you're looking at right now, if you flip into that, it talks about epidurals. That treats disc herniations. It shrinks the disc to the point it doesn't irritate the nerve. Now, another thing we could do today for a couple reasons. One, I think there's already inflammation occurring throughout your body, and plus all the things we just did, we probably aggravated a little bit, and it's, you're gonna feel it tonight. I could give you a short course of oral steroids, which do the same thing as naproxen, but are just hundreds of times stronger. They reduce inflammation, and by using them orally, it's gonna reduce it in your neck, your arms, your back, everywhere. It's gonna get everywhere in your system. So it'll help to minimize some of the flare-ups of what we caused today, but also more importantly, just reduce some of the inflammation that's already there, right? If you don't want to use steroids, that's fine, but I definitely think naproxen. If you do want to use the steroids, you just use it for 6 days. It's 6 pills on the first day, then 5, 4, 3, 2, 1. It tapers you off over those 6 days. But at the same time, when you start that, go ahead and start naproxen also. So as that one tapers off, the naproxen is ramping itself up. Because remember I said it takes 7 or 10 days, right? So you could try those things. You don't have to, decide whether or not you want to do these things yet. What I might suggest is maybe we'll make some adjustments to the, give you a chance to talk to your doctor about maybe switching gabapentin over to Lyrica. With the medicines you have already, you could make your own. You could slowly titrate yourself down on the pain medicine there, and then start incorporating anti-inflammatories and just see what those adjustments do for you. If you feel like it's better, but it's still problematic, then we can say, okay, well, let's be more specific now. If this is the problem, let's target that pain, and then we would know what our next step is. But to go in there and do these procedures right now, I think because there's so much going on, I think you'd have a hard time being able to tell whether or not they help because of all the inflammation that's occurring throughout your body everywhere. So I think we need to get that under control first before we consider doing any of these shots or anything. Right? So I think that's a good first step.
And you're saying the lower back is just epidermal shots?
No, the legs would be epidurals.
Right, and
The radio frequency would be to treat the lower back pain.
Okay, like if I wanted to do the radio frequency for the lower back pain, because I'll be honest with you, like epidermals, I don't think I'll ever do. Yeah, but I mean, as far as like taking the leave, I'll do that and get off the other stuff. But like as far as like epidermals go anywhere, I don't think I can ever do that. Like not mentally.
Well,
I mean, I've had
not,
cancer. I mean, not even a year ago, and I went through hell.
Whether
But the other thing, the electrical thing, I could probably do.
So it tends to work better. I really like that procedure because we don't rely on steroids for long-term improvement. We're actually just getting rid of the nerves that go there, at least temporarily. I mean, when we do that, those nerves do have the potential to grow back. If they grow back, it's typically 10 to 12 months, sometimes earlier than that, sometimes later than that. That's about the average. So if we do it and it works, sometimes we have to repeat it. In other patients, I do it once and I never have to repeat it again. But again, everybody's a little bit different in their responses to these things.
Okay, so
And
we'll
again, we can even look
focus.
into see whether or not, having it done at a surgery center where anesthesia can be provided as an option for you.
I'll do like the shock thing for my back. We'll start there because that's the worst of it.
Mm-hmm.
And I know my friend Dave, he's been here. He
Uh-huh.
says that it's not that bad. So we'll try that. Let's
Okay.
go with that.
Yeah.
And,
Let's do that. We'll go talk to Mary. She'll let you know what times and dates and stuff are available for that, and we'll go from there.
Yeah. Okay. Yeah.
Go from there.
I'll start off with that.
That's
'Cause,
Like I said, my concern is with inflammation that's occurring throughout your body is when we do this procedure, this part of it here, right? We do this diagnostic procedure where we numb the nerve up that goes to the joint right there. Well, doing that procedure is gonna cause some damage to the tissue, although it's not much damage, just because it's a little needle going in there. But still, with all this inflammation, it might aggravate your pain. So being able to differentiate between your usual pain and procedural pain will be an important distinction there.
right.
And that's something that before doing that procedure, I would want you to kind of pay close attention to the pain that you have back there, as far as its quality, where it goes, just the overall nature of that pain. Because most people can differentiate between the pain that they live with on a regular basis versus the procedural pain. Right? You can get a flu shot, you're gonna be sore when you
Yeah,
get the
yeah.
shot. Well, same thing here, you're gonna have some soreness from that, but that's not what we're evaluating. We're evaluating what happens to your normal pain. So in the days leading up to it, make some mental notes about, all right,
Yeah.
what is this pain like? And really focus in on, the qualities of it. Is it a dull achy? Is it a sharp shooting? What kind of pain is it? So you have a better understanding of your normal pain fresh in your mind, so that you can differentiate that from procedural pain.
Oh, I'm good.